Good afternoon, everyone, and welcome to Communicating with Confianza, a health literacy eco series. My name is Dr. Raquel Romero, and I will be the eco facilitator for the session today. This session is brought to you by Health Confianza team in collaboration with the UP Health San Antonio Super Hub, the YMCA, South Central EHEC, and the University of Texas at Austin. Please let me start by saying that Health Confianza is a community-wide health literacy program that aims to provide health literacy education, training, resources, and workforce development for Bejar County and the surrounding areas. Confianza is the Spanish word for trust. Our team believes that health literacy is critical to transform health and to achieve health equity for all. With the goal of increased health literacy in our communities, these sessions were carefully planned to equip with tools and skills to all of those who attend the session. And we may have different reasons to join this session, but there is one consistent thing that I believe brings us close together, and is the desire to have a deep understanding of health literacy. So please join us for our following sessions. And I invite you to explore what we have been offering for our following sessions. Thank you so much for your trust and your support in us. For those that are new for the ECHO sessions, ECHO stands for Extension for Community Health Outcomes. Our virtual telementoring platform is specifically designed to have connections between communities and subject matter experts. The ECHO sessions have the following components. We have opening, welcome, then we have the introductions and announcements, we have didactics, and then we have a case presentation and a group discussion. So I invite you to consider to present or submit a real life story. If you are interested to present a case, please contact the administration ECHO team for more information. And please remember that no personal health information, PHI, is allowed to share at any point on this session. So what is PHI? Or personal health information is DOB, date of birth, addresses, appointments, etc. Now, before we go to the introductions to our Confianza team, there are a few technical points that I need to mention. Please, to help us with our attendance records, please enter your full name, affiliation, and email address in the chat box. And if you have any problems, any connection issues, please send a private message to our ECHO IT for assistance. And we promote interaction in our sessions. If you're able and comfortable, we invite you to join us by video, particularly in the discussion part of the session. So I would like to now move to the introductions to our ECHO team, and I would like to start with Dr. Rosenfeld.
Hi, good afternoon, everyone. I'm Jason Rosenfeld, Associate Professor, Department of Medicine at UT San Antonio, Director of Global Health Education at our Achiever Center. It's wonderful, and co-director of Health Confianza. It's good to be with you all today.
Thank you very much. We have Dr. Cantu, Adelita Cantu.
Sure. Good afternoon, everyone. My name is Adelita Cantu. I'm at UT Health San Antonio and the School of Nursing. Thank you so much.
And lead specialist today. Thank you very much. We have Dr. Dacso as our didactics presenter today.
Yep. Hi, everybody. I'm Dr. Matt Dacso. I'm a physician, general internal medicine and hospital medicine here at UT San Antonio in the Long School of Medicine, and I direct the Achiever Center for Medical Humanities and Ethics. It's a pleasure to be here with Health Confianza.
Thank you very much. We have Dr. Melanie Stone.
Good afternoon, everyone. I am also with UT San Antonio. I direct our Community Engaged Learning program at our Achiever Center for Medical Humanities and Ethics, and I'm faculty in our Family and Community Medicine department, and I co-direct Health Confianza with Jason. Thanks.
Thank you very much. And Dr. Wu, who is presenting the case today.
Hi, Junda Wu. I'm the medical director at Metro Health, your local public health department.
Thank you very much. And just as a quick reminder, towards the end of the session, our team will send you out a link for the continuing education credits and evaluation of the session. And these sessions are possible because of you. So your feedback is very, very important for us. And finally, I would like to mention that ECHO is all teach, all learn environment. So we encourage and invite you to share your experience, your questions, and your insights to our conversation today. So we know more from my end. I would like to give this space to Dr. Dacso for the didactics presentation. Thank you.
Wonderful. Thanks so much, Dr. Romero. As I mentioned before, I am Dr. Matt Dacso. I'm a internist, and I think you can see my slides. So I I was approached to invited to do a talk to Health Confianza, or to this learning community. And I thought long and hard about what it was I wanted to talk about. And one of the things that has for many years been coming up in my practice in primary care, and I know many of you face it in the community, is helping people understand sort of what's a genetic problem and what's an environmental or a lifestyle problem, right? And communicating about how these things are so complicated and intertwined can be somewhat difficult. So over the next 20 or 25 minutes, I'm going to just go through a little bit of the background, and then I think maybe share some ideas of what I've learned in practice, and certainly through my literature review, what I've found are some ways that we might be able to communicate about this very complex topic. So I'm going to... There we go. So my objectives are to explore how both our DNA and our life experiencing affect how our chances are getting sick and staying healthy. So this is very, very complex interplay. We're going to talk about it. We're going to talk about some of the healthcare practices that people are accessing in the community, some of the new technologies that are out there that people may ask about, so that address both genetic and lifestyle factors that affect health. And then finally, we'll go through some strategies to communicate uncertainty, especially about what we know and we don't know about these things, and address the risk conferred by genetics versus the lifestyle or the environment. So I want to kind of just set the stage with the following, which is that we have greatly expanded our knowledge about what the genetics, what our DNA does for our bodies and what it does for our risk. But we also are constantly learning more about how lifestyle, how environment, how socioeconomic conditions play with the DNA and affect our DNA and affect our bodies in a way that actually can cause social conditions to become part of something that integrates into the health of our next generations. We also know that technology is always evolving very rapidly, and this can be very hard for our patients or for the clients or for members of the community who are just trying to figure out, what to do for their health. There's a lot of access to information, so people can access more and more information about their personal health. They can go online, they can go onto ChatGPT, they can access all kinds of tools that for a long time sort of just lived in medical environments, but now are much more available in the community. But we also know, as we're all in the health literacy space, that the level of health literacy in our community remains low, and that affects not only how people access our information, but also how they use that information to make their decisions. And then finally, I just want to say that, I've been around the discussions, especially around AI and ethics and a lot of technology and the regulatory environment that we are in. So the governments or the rules and regulations that we typically follow are not really, they're sort of behind where the technology is. So these are kind of setting the stage for where we're at. So these are some questions that have come up in my practice in the past. Things like, my father had a thyroid problem. Will I have a thyroid problem as well? Everyone in my family has had bad reactions to vaccines, right? So people will come and say, well, since my family had a bad reaction, I feel like I'm going to have a bad reaction to vaccines. Depression runs in my family. My brother smoked for 50 years and never got cancer. I never smoked and I have cancer. Why is that? And then finally, I got a genetic test online or in a box, or I sent it in, and it says I have a 40% chance of developing Alzheimer's. Is there anything I can do? So these are the things that people are coming with. They're coming into clinics. They're coming into practice settings. So I want to just take the zoom lens way out and start with DNA. All right. So the genetic code, for those of you who are in clinical practice, we had to learn this in school. Many of us learned it in biology. It's probably rusty for most of us, but the central dogma of the world works on this fact that we have a genetic code. That genetic code is DNA. It's transcribed into RNA, and that makes proteins. And all of that That's the way that our bodies work. That's the way that our bodies are created, that we age, that we develop illness, that we get better. Okay, DNA sets the stage, and then RNA to protein is the central dogma. We also know that just because you have a particular gene sequence doesn't mean that it's going to turn into the thing that that sequence translates to. All right, so there's this thing called a phenotype. So there's a genotype and there's a phenotype, and the interaction with the environment is what makes you look or act or manifest a particular translation of that gene. But then, so we know that also in complication with DNA is that we know that the social determinants of health are very important. These are some of the seminal studies that were done back starting in the 60s that for the first time documented a relationship between social class, as you can see at the bottom, so administrative, professional, executive, clerical, and other, and risk of disease and even death. So they showed that higher classes, so people with a higher socioeconomic class, had lower burdens of disease, okay, and lived longer than people who were of lower income or lower socioeconomic status. Okay, and this was on a ladder. And so this was really the first time this had been demonstrated in a large population. It was in the UK, and it was the Whitehall study. So we really started to think about, well, it's not just genetics, but social conditions really can shape how health manifests in the body. This gave rise to this figure, which we all know and we all are so familiar with, which is, the social determinants of health framework. So at the core, we have your factors that are your genes, your own personal risks. And then on the next level, you have your lifestyle factors. Then you have your community networks. Then you have all of the other factors that are outside of those networks, like the work environment, educational level, employment, access to health services, housing, et cetera. And then on the way outside are the general socioeconomic, cultural, and environmental conditions of where you live. And what's interesting is that as we've gone through time, we've started to see a unique interplay that I'm going to go through in a second. But in this modern era, we're in the Make America Healthy Again movement. This was a result of some studies that were just issued in the last month. This is by Navigator Research. They are a polling company, and they polled thousands of people. And what they found is that in the world right now, in our country, this movement is quite popular. So about 43% of people who they surveyed actually found what these policies that the Make America Healthy Again movement were pushing was quite popular. And a lot of these have to do with lifestyle factors, things like food and food safety, environmental safety, water safety. And so there's a lot of things that people find very popular, but that, and the reassuring thing is that health professionals remain very trusted. Okay, even though I think we like to think that there's a lot of misinformation out there, people in the health professions remain quite trusted sources of information. So we're in this moment where I think we used to focus a lot on genetics, then we learned about the role of socioeconomic forces in the environment, and then we really now have focused very much on the environment. And so somewhere we have to figure out how to communicate with our community about how complex this is. So again, starting with the very basics, people often confuse the ideas of genes or genetics and genomics. And I just want to sort of really quickly tease those apart, because that's an important thing that people don't always understand in the community. So that gene is just a sequence of DNA. That's all we're talking about. And when we talk about genetics, we're talking about how genes are passed down. And usually genetics just focuses on what that gene does, what it is translated to in RNA, what it makes in protein, and then what the phenotype looks like, okay, of that particular gene. Genomics looks at the entire structure. So many times when we talk about the determinants of health, we talk about genomics because we're talking about how all of these DNAs relate to one another. And then we study how they interact both with each other and with the environment. So genomics focuses on a lot of the genes and how they relate to one another. When we talk about the non-medical drivers of health or the social determinants of health, we all know this. These are the conditions and the environments where we are born, live, work, and play and worship. And these affect a wide range of health factors and quality of life outcomes and risks. And we know that the social determinants of health, this is not an exhaustive list, include issues like economic stability, healthcare access, where we live, et cetera. So what is the biological impact of some of these non-medical drivers of health? Well, where we can study this, we have seen that there are effects on the body that come from the environment. Things like your brain hormones, so neuroendocrine system. So the way that your brain metabolizes, processes hormones, and how those influence how your brain functions can be impacted by a potentially stressful environment. So imagine like your adrenaline is always up, right? Your cortisol is always up. Your energy is always stressed. This can affect how your brain functions. Stress and other factors in the environment can affect your developmental milestones. We know this from the literature, from the adverse childhood events literature, that there are potentially limitations or delays in developmental milestones for youth that are living in poverty or in situations of lower socioeconomic status. Inflammatory things, we know that these environments can be stressful and they can induce inflammation and even reduce the ability of the immune system to respond appropriately. And then there are vascular effects. All of these are interrelated, where inflammation, neuroendocrine issues come to bear on the ability of our body to deliver blood to the organs that need them, right? So all of these things have been studied, and there have been shown to be some associations between the environment and these effects in the body. Most people refer to this as epigenetics. So when we talk about what is it that the environment is doing to your genes, that epigenetics is the study of how all of these things fit together and how these environmental stressors, these environmental influences, turn on or off certain genes. If you remember, I said the DNA sequences are there, and you can either turn on the sequence or turn off the sequence, and you do this by a variety of ways. The point here is not to make you all geneticists or experts in genetics. It's to show you that there's actual science behind what people say and what they feel. So when someone says, I'm in a stressful environment, I feel like there are people around me who have higher rates of cancer or have higher rates of heart disease. Yes, some of this is the lifestyle factors, right? Maybe it's not having availability of nutritious foods or well-balanced diets. It's more processed foods. Maybe it's genetic risk, but it's probably some combination of all of them. And we're learning more and more about how the influence of the environment on what happens in our own DNA. Okay, so this is an area of a lot of evolution and a lot of advancement in knowledge. So I want to give you some examples of what purely genetic conditions might look like, because it doesn't mean that all diseases are like this. Some diseases really are much more genetic in nature. For example, sickle cell disease. Sickle cell disease is something you'll find in the community. It is genetically transmitted. If you have the gene, you have a higher risk of having the disease. Huntington's disease is another one. This one causes profound issues with neurodevelopment. It's passed down genetically. Cystic fibrosis, these are mutations in the genes that are passed down in the family and can affect your offspring or the next of kin. Then there are ones that are a bit more clear that it's a combination of your genetic risk and the environment. Things like coronary heart disease. We know that people who have a family history of early coronary disease and have certain genetic risks, they have a higher risk of getting coronary heart disease themselves. So maybe someone who has more genetic risk, right, may want to make different decisions in their lifestyle, right? So we use this to help people make decisions. Type 2 diabetes there's genetic risk and there's environmental risk. We know that there are people who have it in their families. There's some people who go on to develop diabetes, who had a family history because of potentially food exposures, high sugar intake, et cetera. Asthma is another one that is genetic risk and environmental risk. Okay, so it's almost like the genetics set the stage, and then the environment kind of closed it down, and then now they have asthma or they have type 2 diabetes. Now it's complicated when we get into things like type 1 diabetes, which has a genetic component. Okay, but maybe there's potentially people are still researching, is there a virus or is there another exposure that turned off or turned on that genetic risk. Most cancers actually are quite complicated. Is it something in the lifestyle, or is it something in the genes? And it's some combination of them, and it's quite complicated, and we're learning more. And then autoimmune conditions. This one comes up a lot. People will say, well, I have these chronic joint pains, or I have these, people will say I have rheumatoid arthritis, but they've never been diagnosed with rheumatoid arthritis. They have something else. So these are conditions where it's very complicated, whether it's the genetic problem or whether it's the environment problem, and we're still learning more. So I want to move to what people might be doing to get information about this and where some of the information might be coming from. So one of the things we've seen, especially in the last 10 years, is a lot of people signing up and sending in a hair strand or a fingernail clipping or something to get their gene sequence. So they want to see what's in the gene. And, this has really been very interesting for people in clinical practice, because we don't always know how to use this information, right? We don't use this as a clinical test except in very specific conditions. So when a patient comes or a member of our community comes, says, I have this, interpret it for me, it's very hard for us in clinical practice to do, because we weren't really looking for it. So there's some pros, right? In rare diseases, it can help you find things. It does give people a sense of empowerment over their health. So they like being able to do their own testing. It can destigmatize some illnesses. It's also non-invasive. So you don't have to do a blood prick. You don't have to do some kind of a biopsy. This is very easy to do. But there's some cons. It doesn't, people are trying to figure out, well, what are my genetic background? I have this percent Alaskan Native. I have this percent Hispanic, this percent this, that. It doesn't test for all variants, diseases, or ethnicities. It's also not clear how we use it clinically. So we don't really always know how to use this clinically because the risk environment is so complex. It's not just the genes. It's also your environment. Often these are used without any counseling, so people aren't really asking for any guidance before they get them. And all of this needs to, if you find something, it needs to be confirmed with other tests, which could be more invasive. And then there are big issues around privacy. They've been hacked. So questions about whether your genetic code could potentially just be out there in the world. How do they protect that information? This is all some of the issues that come up. So I like to think about the tools that people use as being sometimes very useful. So one of the things that's come up in the last several years is cancer screening decision tools. And so people can go online and they can put in some information. And as part of their genetic education and counseling, they can look at their potential risk for cancer. So what is their personal, and they should be using this if maybe they have a family history of cancer, or there's potentially a bunch of cancer in the family. Maybe they do want to do some cancer screening or some genetic testing. Maybe the genetic test needs to have the right kind of diagnostic accuracy. And we should use it if the test will impact some clinical outcome or clarify the risk. Some people just want to know, what's my risk of passing on this gene or this risk to my children, right? And so as part of a controlled or careful discussion, we can have that conversation, we can screen, we can accept margins for error, and we can figure out how to help someone with risk. The other things that people are accessing these days are clinical services that I wanted to just make everybody aware of. This has become very popular in the last 5-10 years as people have faced access issues to conventional medicine, as they become disenchanted. Maybe they haven't felt listened to. They're going and seeking other things, right? So you may hear people talk about personalized or precision medicine. when we talk about these are practices where a clinician will use information about an individual's genome, their environmental and lifestyle information to help guide their decisions about medical management. And the goal of this is to provide much more precise prevention, diagnosis, and treatment of disease. So we are an individualistic people. We like to know, what's my individual risk? I know that my community has this risk, but what about me? Personalized and functional or precision medicine tries to get at the individual, though when you look at the statistics, it doesn't deliver necessarily much more precision than what you'd get from a big population study. Functional medicine is another one. This one looks at underlying processes and dysfunctions. So maybe it's an inflammatory problem, an adrenal problem, a liver, or too many toxins. I mean, functional medicine requires a lot of testing. So people will go and they will get, 1,000 tests, like of different hormone levels and different chemicals in their body. And with all of this, they're trying to make, again, personalized decisions about balance, health, and well-being. And so people often will kind of lump precision and personalized medicine under functional medicine. But the idea is that people are doing genetic testing, and then they're doing all of these environmental tests as well to see if they can help people make better lifestyle choices. Issues with this is that most of our medical issues don't rely on just one gene. They rely on multiple things interacting with one another, and there's a lot we don't know. So it involves interplay with the environment and behaviors and lifestyle. These are also very biomedical models. These large panels of tests are often expensive and difficult to interpret. They're not cheap, so it doesn't necessarily make it easier for your patients or your community to access care. And they are often marketed directly to people. So you will get people asking you about these services, and we often don't know what to say. And then there's a lot of ethical issues. Are people acknowledging what they know and what they don't know, and what they can interpret and what they can't interpret, right? So this is an evolving area that I think we're going to see more of in our community. So I'm going to finish in the last few minutes about how do we communicate about this. So I think this is kind of what the crux of it is. We know all this stuff. We know there's a lot of uncertainty, but how do we help the people who have questions for us? So William Osler, who was sort of the father of modern medicine, said medicine is a science of uncertainty and an art of probability. So no matter what health profession you are, if you are in the health field, then you are dealing in uncertainty, and there's a bit of art to it. And then Voltaire said, uncertainty is an uncomfortable position, but certainty is an absurd one. So I always find that the more certain people are about something in what we do, which we know is so uncertain, then it starts to sound a little absurd. So some general guidelines. People are smarter than I think we give them credit for. And actually, they can understand that things are not well known. And we can tell them that, like, when we talk about uncertainty, we're really talking about risk, and that we also are learning more. So I have found in my experience, when people are met with an understanding that, I'm going to tell them what I know, what I don't know, and then that there's what I say can change in 5 years, people are generally pretty tolerant to that. So most people like to have you present information in multiple formats. I know there have been some speakers that have done that. So instead of saying 10% of people, say 10 out of 100. Be conscious of how you're framing things. So framing bias. So you need to give both positive and negative perspectives about the risk that you're communicating. Using pictures, but choosing carefully. I'll show you some examples in a second. Denominators are important. So, if you say your risk is 1 in 10,000, people can't really visualize that. Or 100 out of every 1,000, say 1 out of every 10, because people can picture a room of 10 people, but they can't picture what 10,000 look like. Less is more. Don't talk to them about the genetic code unless they really want to know about it. But talk to them about what we're learning and what we know about the complexity of the interplay between the genes and the environment. Be aware that a lot of risk information is often distorted by emotions. So it's people's feelings. They may have been harmed by the system. They may have been not listened to, and they feel like, they need an answer. And sometimes not having an answer can feel frustrating, but it's better to be honest with what you know and what you don't know than to start leading someone down a path. And then engage people in the process. Some people want to participate and calculate their own risk, and so you can send them evidence-informed ways to do that. So, as I said, most people perceive risks as acceptable if they're voluntary or if they have choice, if it's under their control, if there's clear benefits, if it seems naturally occurring, if it's generated by a trusted source, if it's familiar. Um, but people won't accept risks that are maybe being imposed. We saw this during the pandemic. A lot of the communication, a lot of the issues that people have brought up are about things being imposed, things being controlled by others, not having clear benefits, where it's human made and not natural, if it's generated by an untrusted source, etc. So like communicating the risk is also involves what people are usually willing to tolerate. So like I think during the pandemic, we saw this is a great communication tool. When people didn't understand risk, you could show them the Swiss cheese model and they were like, oh yeah, that makes sense. Like the pathogen starts here and we have all these different things we put in its way to prevent it from happening to me, right? This was a great tool that got widely circulated, and I think it helped a lot of people. It certainly helped a lot in my clinical practice and in my public health practice. Um, Tools for communication about risk of cancer. So like looking at a bunch of percentages is going to overwhelm most people, but this is quite clear. Look, oh, cigarettes, that's high. Alcohol, that's higher. Okay, well, physical inactivity, it doesn't mean that these are, that they're all risks, but we can look and we can start to make our own decisions, based on what these risks are. So it's always good to have awareness, empathy, humility, transparency, and then empower the people who are around us. So I'm in the last 2 minutes, I'm just going to give you a few answers. These are just what I came up with to the first questions that my patients posed, and I sort of wrote these up. So like, for example, my father had a thyroid problem. I assume I'll have one as well. Should I get tested? Well, say, I understand why you're concerned. Some can be genetic, but those are pretty uncommon, only about 5 out of 100. And since thyroid problems are common in the population, there's not any great recommendations on doing screening or testing without symptoms. So in your case, I think we keep an eye on things and test you if and when those come up. So we've reassured the patient, we've told them that this is normal, that it's okay to have worries, that we've reassured them, and we've said that the risk is quite low, and we will let them know if things change. How about everyone in my family has bad reactions to vaccines? Well, I understand why this might worry you then. You clearly have seen something that's disturbed you. So getting a vaccine triggers your immune system, and it makes chemicals that prevent infections. And certainly genetics can influence how our immune system responds, but it's not just that, it's so many things. If you're in a room with 100 people, up to 10 of them might not even generate a response to vaccines. So that's why we do studies, we look at big populations, and we're still learning so much. And what this means is that there's so many variables. So just because a family member has a reaction doesn't mean that you will as well. But it doesn't mean it's zero. If we say that you're never going to have a reaction, we're going to alienate the patient, and then if they do have a reaction, they're never going to vaccinate a kid again, right? So in the interest of time, I can send these a little bit later. My answers are all very long. I really want to just go to the resources. I have a few resources. I love the De Beaumont Foundation. Anybody who knows Brian Castrucci and his team, they're always trying to help people communicate better about public health. And then for a good example of a good risk tool, I did it actually before this talk. It's a really good personalized risk tool that takes your own personal factors, puts them into a thing, and generates a good recommendation of what you should and shouldn't do. So I'll go ahead and stop there, and I think I left enough time.
Thank you very much. Thank you very much. This is very, very interesting presentation. And thank you for help us to understand a little bit better the science behind how environmental plays an important role in some conditions. Very complex topic. Is there any question for Dr. Dacso? Any comment, any question? Very complex, very interesting. I
Yes.
think I have a question.
Go ahead,
Adamo?
you can unmute.
Adamo? Would you please unmute yourself?
Yes. Thank you for the presentation. That was very informative. Yawa Adamu from School of Public Health. So, being in environmental and occupational health department, and also seeing how much environment contributes. So, as a clinician yourself, how well do you think, like, clinical community are ready or receptive or being aware to kind of explore this aspect when doing differential diagnosis?
That's a great question, Damu. Thank you. Boy, I think people are definitely more aware of it in clinical practice than they used to be. I think we were always very biomedical, and we learned about the environment only in as much as it influenced specific diseases. And I think as medical education has evolved, I think we get more in the curriculum about social determinants of health, about culture, about different practices, about environmental exposures. And I think we've started to introduce the idea that there's a lot we don't know, and we have to teach our students how to communicate about what we know and we don't know. But I'm actually glad Joel is raising his hand, because maybe he has a different perspective, to add on that. But I think I do think there's still work to do on getting more sort of environmental and public health content into clinical education, because as you mentioned, we do tend to, it takes us a long time to evolve how we're training our students to address these problems. But I think we're at least here. I know we're trying, and I know at a lot of institutions they are as well. But maybe Joel has a perspective as well.
Thank you.
Dr.
No, I was just
Savar?
yeah, thanks. I was just gonna comment on multiple testing. You said some people get 1,000 tests. Statistically, 50 of those are going to be abnormal, right? And so, what do you do with 50 abnormal results, which actually may not be abnormal clinically, right? And so when patients come in and say, "Why shouldn't I test for thyroid, skin cancer, whatever it is?" that has to be explained, I think.
Man, you're right on, Joel. I mean, that's one of the most common conversations. That's why I think it really does come down to, that trust discussion, because I think people like to trust the objective things over the conversation with their clinician. They see these tests and they're like, this is way better information. But people don't always understand that those tests they have a margin of error. Most of them are uninterpretable. They're not routinely checked for or tested for. And so, I've had, I'm sure you have too, I've had people come with a ream of paper with 500 tests. And I say, they said, look, my insulin was this. And I said, I don't know what to tell you here. I didn't order it. I don't know what the pretest probability was. We use the tests in clinical reasoning. We don't use them in the same way. So you're right on that a lot of them are going to be uninterpretable.
Thank you very much. And I also see two hands up. Guadalupe Cornejo, do you have a question or comment?
Yes. I think my question was partly answered, but because my question was, in what conditions is there a resource that lists those conditions that are more common that there is a genetic test available? And I'm thinking about how that influences people's behaviors on encouraging early screening for conditions that there is actual need for, and also of course to influence lifestyle changes. Just because, yeah, like you mentioned, there's a lot of information and there's a need certain segments of the population to get tested, right? And I imagine those tests are not cheap. So, when we're in the community and people come to us and like, will you recommend I test for do the genetic testing for this? Like, to have a resource that says, the pros and cons and then what do you do with this information with your provider? Or what are the possible uses, like you were mentioning?
Yeah, that's a great question, Guadalupe. Thank you. And I think it's a tough one because, um, boy, there are situations, there are conditions that I think we know we should screen for early. That if there's a family history or there's a potential for a genetic risk, like if someone has had BRCA positive breast cancer, we know that we need to screen for that, and sometimes we have to intervene early in their first generation, in their first generation relatives or their kids. It's part of genetic counseling. It's part of the sort of the comprehensive approach to good, solid preventive care is knowing your family history, knowing what the genetic risks are, and then being able to work in your ideal environment, work with a clinician to decide which conditions you're going to do screening for. Maybe there are situations where, wow, we've had a lot of Alzheimer's in the family. It'd be really good to test for these very specific things and then do appropriate modifications early. But as we know, as I think someone raised in the chat, these are not equally available in the population, and so access to that kind of counseling is not always there. So I think to your point about what do you say, I mean, I think it's always that there's got to be a grain of salt. If someone is going to do their own testing, they're going to be like, well, I want to go ahead and pay the $50 and get the test of my genetic stuff. It's that we don't always know what to do with that information. Just because it has a genetic risk, it doesn't always mean that it's going to turn into something, but it can start a conversation. So I never tell people not to do it. I just tell them that we have to interpret the results with a grain of salt. So I don't know if that answers your question, but it's a really good one, and I think it speaks to what what we really are able to do in clinical practice and how we help people make decisions about preventive care and screenings.
Yes, thank you so much. And one more question, sorry. The ATM gene, is that prevalent in certain populations more than others? That's related to breast cancer, colon cancer, and other common
Yeah, I'm
cancers?
not as familiar with that one. I wish I
Okay.
could answer that question. I don't
No.
know too much about the ATM gene.
Okay, thank you.
Well, thank you very much. And I thank you for all your questions. And if you like, we can continue in the chat, but we have a case to present in this session, and Dr. Wu is ready to present the case. And again, if you have more questions, Dr. Dasho, thank you so much. This is very informative and it create a lot of questions in our group. Please just put the questions in the chat and we want to keep the conversation. Thank you very much, Dr. Wu, on your time. Thank you.
Sure, I understand why people wanted to keep talking about Dr.
I
Dasho's great
know.
presentation.
Exactly.
And mine is going to be going in a totally different direction. We're going to talk about sex, one of my favorite topics. And I particularly wanted to highlight a theme I've noticed where sometimes we teach adolescents things using scare tactics, and then what I sometimes see in clinic is the opposite effect that was intended. So one example that I've put there is that, in schools, to the extent that sex ed is there, it tends to focus on symptoms and show these really graphic images. And so what people don't realize is that a majority of STIs have no symptoms. So if, for instance, my lens is as an OB/GYN, so 70% of women with gonorrhea have no symptoms. 80% of women with chlamydia have no symptoms. About 60% of women with syphilis, no symptoms. And HIV, of course, you can have no symptoms for, decades. But if you're of the mindset that you're going to, see these things on yourself, on a partner, then of course you're going to take more risks, right? I mentioned meeting some teenage girls who absorb the message that sex, can make you pregnant. And so then they maybe somehow have sex once or twice without getting pregnant. And then they come to the conclusion that they're infertile. And then they take more risks, and then they might end up actually getting pregnant, which would be how I encounter them. So that's it's definitely not as complicated or as deep as what Dr. Dasha was talking about, but it's information that I wanted to share, and here's some discussion about. I will tell you one of some of the questions that we hear most often in our STI clinic when people come, whether sometimes people just outright ask them, sometimes you anticipate it and tell them, and you can see the whole body relax. Number one, everything you tell me is confidential unless I find out you're going to hurt yourself, hurt somebody else. Number two, this is curable, which is, the case for HIV, I mean, sorry, for syphilis, gonorrhea, chlamydia, not for HIV, but highly manageable. I will give the pitch again that most people who have HIV and have what we call an undetectable viral load, which means they've been controlled for at least 6 months. People could have sex and not even use a condom and still not transmit the virus. That's how strong the medicines that we have nowadays are. We have the technology. People who don't have HIV and don't want to acquire it, they can take a pill every day to not acquire HIV. So it's not the big bad, but a lot that it used to be, but a lot of people I run into still have mindsets that are kind of stuck in the 80s. So the first thing to do is reassure people, and then they have brain space to hear more and talk more. And other common misunderstandings, I would say, the actually those are the main ones that you can not have symptoms, and yes, this is curable. And so I tried to put it in the format of the questions for creating a presentation, but in the interest of time, I don't know, it's not, you can read it. It's really, this slide is just saying what I already said previously. And then I have a couple of slides for maybe discussion, which is, I would love to glean from this group where I see so many names that I know. What do you find effective when you're talking to people about preventing sexually transmitted infections or preventing unintended pregnancy?
Thank you very much, Dr. Wu. I see Dr. Stone.
Thank you for sharing this case, Dr. Wu. So in my early career in public health, I actually managed an HIV outreach clinic here in San Antonio. And so one school of thought, and this was for adults, I know you're talking about teenagers for your case, but when we were working with adults, one school of thought was that by emphasizing the message that STIs are curable, it might convey that people are less likely to protect themselves because they figure, well, if I get gonorrhea, I can just take a pill and it'll go away. And so I'm just curious how that might fit into your messaging.
Yeah, well, that is true. I mean, actually, you would get a shot and it will go away. I think so. That the underlying that, and I know it's not for you, but it's more in what we hear when we talk about infections with our colleagues sometimes. There is a level of maybe even judgment around STIs that we don't see around other conditions. I mean, if I am on a statin for high cholesterol, am I more likely to eat ice cream? I mean, there's probably a fraction of the population that does do that, right? But we don't change our behavior on that account. And we know that so many other people are being more careful, right? So I think that I don't have a problem telling people it's curable. It's even easier to prevent. It's certainly cheaper to prevent than to, in terms of both money or, our clinic is low cost but not free, but also in terms of time, in terms of worry, it is certainly better to prevent if possible. So how can we do that for you? But people self-soothe or take risks, which sometimes is a part of self-soothing or dealing with stress in a lot of different ways. And some of these are socially sanctioned, right? Alcohol is very socially sanctioned, even though it is also it is the most commonly abused substance. We've got overeating, we've got undereating, and some people, especially people with 4 or more adverse childhood experiences, are more likely to take risks when they have sex. So it's we just give the information, meet people where they are, and slowly work on different ways to layer on different ways of protecting yourself. Which I would say another thing is when I ask about how people, what strategies people have to lower their risk for infection, number one, I phrase if we come to condoms, because condoms are not the only way. I will phrase it as, are there situations where you use condoms? Because if you say, do you use them? Sometimes people feel very put upon to just say, yeah, I do, right? So you got to leave the door open. And it's not just about condoms. It can also be about limiting your number of partners, limiting your number of partners. Sometimes people, use oral sex as a way to lower their risk. It's just like when we're talking about COVID. How do you layer on your levels of protection that work for you?
Thank you very much, Dr. Wu. I see Corinne Reyes. Do you have a comment or question?
No, yeah, I'm just going to answer the question she asked how we teach sex. So for us in our youth programming, we teach that sex is more fun if you're protected. So it takes the scariness out of it just by being like, hey, you'd have more fun doing this if you don't have to worry about catching something or getting pregnant. So wrap it up. So that's how we teach it.
Yes. And another thing that bothers me about the usual conversation about condoms is it doesn't account for the fact that some people don't feel empowered to use condoms, right? This gets into the whole power dynamics in a relationship. Sometimes we're talking about partner violence, issues that would take well more than the rest of this time that we have. But yes, thank you, Corinne.
Thank you, Corinne. Dr. Ramos, I see also you have a question or comment.
Yeah, yes. I'm just curious about the confidentiality on Texas. When is appropriate to do that without infringing the parents' consent? As some of these are minors. And the second question is, when do you know the teenager is ready for this conversation? How young to start? Just curious, it's a general question.
So in Texas, the standing rule has been that teenagers can get tested and treated for STIs without the parents' consent. Now, I will say that with the last legislature, there are some changes that our lawyers are looking at because of a lot of parental, I think it's SB 12. I hope I'm not getting it mixed up with HB 12, but there are some things in there to consider where parents might have more access to look at those records, even if they are not needed to provide consent. Okay. As far as when a teenager is ready, so I have less insight on that as a provider who briefly meets the person, but they're ready because they're coming to me because they have an STI or because they're pregnant, right? But from a parent, there's always something that is age appropriate that you can tell that still helps people be safer, right? When they're very younger, maybe we're just talking about what's safe touching, and as they get older, whatever they're specifically asking about, and you don't have to go into what your kids are not asking about.
Thank you very much, Dr. Wu, for this answer, and you, Dr. Ram, for the question. I see also Dr. Roosevelt.
Yeah, I also wanted to just share a little bit of my experience with sexual education. I'm biased. I've used it. It's a great program, Big Decisions, which was designed by Healthy Futures Texas. If nobody's come across it, is an amazing abstinence plus curriculum that is state approved because it does emphasize first and foremost, that the best way to stay healthy is to not have sex, but recognizes that people are probably still going to make a decision. And then there's a lot of conversations thereafter. So I think it's wonderful, and it engages people and young people. I've used it with adults in international settings, and they've received it just as well as young people have. The second piece that I wanted to share that I think is relevant to this conversation is, because this is such a sensitive topic and it's wrapped up in culture, it's wrapped up in faith beliefs, it's wrapped up in political conversations. What I have found when we try to have these conversations is, don't start there if you don't have to. Start with chronic illness. Start with something that is less sensitive and stigmatizing, and let the group build a relationship with each other and trust, because then they will be more willing to have the conversation and engage in a dialogue about their quote unquote true beliefs or their feelings. So those are some of the things that I've seen work both locally as well as internationally.
Yeah, thank you so much. This requires a trust and communication. Yes. Sarah, do you also have a question or comment?
Yeah, it's more of a comment. So I'm a pharmacist by trade, and reproductive health is one thing that I just love and have a passion for. I'm actually clinical faculty with UT at Austin College of Pharmacy. And so I bring this up because myself and a group of others just published a position statement on reproductive health and rights. And, you know, some of the data that we found in regards to education and abstinence-only education versus a more diverse educational profile, you know, we basically have found that teaching about sex ed does not drive individuals to have sex. Providing the information, I think, is key, and how we do that is, you know, another thing. And then, yeah, as far as the laws go with parental consent, and this one really hurts me, but if I, as a pharmacist, wanted to, you know, have an outpatient reproductive health administration and prescribing under a collaborative practice agreement, you'd have to get parental consent before any minor could get some sort of contraceptive, which I personally think is very upsetting. I'm a mom I have 3 kids, 2 of them are girls. And I know how it is as a teenager. We've all been there, right? They're curious. So I think providing them with all of the tools is vital. But that's all I wanted to say. Thank you.
Thank you so much. I'm going to put the Texas rules about what adolescents can consent for in the chat. Thank you.
Thank you. Thank you very much. And for interest of time, thank you very much for sharing that information in the chat. Also in the chat, you will see information for the continuing education credits, and your feedback is very important for us. I would like to take a minute just to say thank you. Thank you. Big thanks to Dr. Dacso for this wonderful learning opportunity. It was a wonderful presentation. We learned a little bit more, a complex topic. Thank you, Dr. Wood, for this case, and I invite you to consider to present a case in our following sessions. Thank you all that were part of this team, and this is our learning community. Thank you, and I will say that our next session is in 2 more weeks, November 21st, and the survey is going to be open until November 12th. That's what it says. And we'll see you in 2 more weeks, and until then, please enjoy this weather and have a wonderful day.